Good morning, dear professors, dear doctors and colleagues. It's Salma Fikri, Department 12 resident, Professor Dr. Hani Hamza's unit. My presentation today is a case during my pediatric ophthalmology rotation. And at the end of one of the tiring clinics that we all look like this, I think residents and assistant lecturers all know how we are at the end of the day after having difficulties with retinoscopy or after the screaming and crying the whole day. So my case was about a 6-month-old female baby, and after proper history taking from the mother, she gave history of 1 month history of gastroenteritis, during which they did routine lab and investigations, and they found that she had elevated kidney functions, for which she was admitted at Abu Rish and took one dialysis session. Later on, 1 month later, she returned back with the same problems and symptoms of convulsions, fever, and also the mother claimed that her baby had an acute onset of squint that resolved on the same day. And then she was admitted to the nephrology department and treated as primary hyperoxaluria suspect and sent for a routine fundus examination. So what did I expect to find at first? I literally expected nothing because I didn't know what hyperoxaluria is. And what I actually found when I dilated the patient properly at the end of the clinic and found that crystals were all over the retina, deposited mainly along the posterior pole and towards the periphery. They were less than the center. And also we requested OCT macula for this patient, and we also found the crystal deposition in almost all the layers of the retina. So what we all do, we reflex everything we don't know about. And what I found, it's known as crystalline retinopathy, which is not only found in primary hyperoxaluria, it's found in many systemic and ocular conditions. They are refractile deposits that have variable origin and composition according to the cause. Systemic causes can be due to cystinosis. Primary hyperoxaluria is one of the causes, Juggler-Larson syndrome or calciphylaxis. Also among the ocular conditions are chronic retinal detachment or macular telangiectasia, gyrate atrophy, calcified drusense, radiation maculopathy. So to pass through what cystinosis is, they are intracellular cysteine accumulation, while Juggler-Larson syndrome, it's accumulation of the lipid and products of lipid metabolism that result in molar cell damage and dysfunction with neuronal apoptosis and photoreceptor damage. Also, primary hyperoxaluria is characterized by having birefringent crystals that can be differentiated from calciphylaxis that are basophilic calcium salts within the vessel walls. Also, crystalline retinopathy can be drug-induced by methoxyfluorine, nitrofurantoin, tamoxifen, flupentixol, methylamphetamine abuse. Also, it can be iatrogenic after intravitreal injection of triamcinolone or ganciclovir. So what is primary hyperoxaluria in brief? It's a rare autosomal recessive inborn error of metabolism where there is accumulation of calcium oxalates in the tissues, including the eye. It can be also deposited in the myocardium. Due to excessive, the kidneys cannot excrete it well, and it has 3 types. Type 1 is the most common type. It accounts for about 80% of the cases, and type 2 accounts for 10%, while type 3 accounts for only 10% of the other cases. It's mainly confined to the posterior pole, like we have seen in our patient, and it occurs 1 per million individuals. It often ends with end-stage kidney problem, especially the infantile type, while the non-infantile type is less severe and causing less ocular alterations. It has variable presentations, ocular presentations, starting from sub-RPE, interrupting the RPE layer, extending to the outer retina with focal hyperpigmentation, hyperplasia of the RPE, with diffuse macular hyperpigmentation, causing disorganization of the RPE layers. Also, it can cause subretinal fibrosis with chronic degenerative changes ending in geographical atrophy of the macula. And also it can end up with CNV in some cases, and those are the multiple OCT pictures, starting from mild RPE changes to extensive RPE fibrosis and subretinal accumulation. And also another case report, they identified that it ended up with optic atrophy and also with extensive scarring of the macula, not just crystalline deposits with or subretinal accumulation. The pathophysiology is still unknown why the infantile type caused more ocular alterations than the non-infantile type, but the first theory demonstrates that there's very high level of oxalates in the infantile type. However, the second theory told us that the infantile type, they have low threshold for oxalate deposition due to the immaturity of the Bruch's membrane RPE complex. So how can we treat it? Trials of low oxalate diet have been used, or pyridoxine supplementation, or increasing the dialysis frequency. However, the only definitive treatment was found to be the combined renal and liver transplantation. And that's what was not available to be done for our patient, and that's why she passed away 2 weeks later. Also, another paper in 2019 concluded that even after the definitive treatment has been done for the patients with combined renal and liver transplantation, it is irreversible. What happened inside the retina is already done. And my take-home message, because I didn't do anything, I didn't manage to do anything for the patient, I just photographed her. So don't ever miss a chance to take a picture. You never know whether it's rare or not. Thank you.
دايما الحالات اللي بتبقى سيستميك اتس لايك ا بازل يعني، وزي ما انت قلتي كده على فكره هو جوجل برضه ميد اور لايف ماتش ايزير. مش دايما بنشوف الحاجه ونبقى عارفين سبوت دايجنوزز. You have to meticulously examine the child, take very good history. بتشوفي عندك المنظر بتاع crystalline retinopathy, you know what it is, you put it, this is one piece, في renal problems, and then sometimes the answer is ان انت تبقي عارفه ان انت ازاي تبيك اب الباثولوجيز اللي عند الطفل.
طبعا نايس كيس طبعا، وهي الميزه برضه كابوريش ان انت عندك البيدياتريك ريفيرال، فبيديكي الديزيزز وانت بتبحثي بقى ايه الاوكيولار مانيفستيشنز، وسام تايمز هم بيبعتوا لنا عشان احنا نشخصهم. يعني بيبعتوا لنا بصوا على الفنجس زي الارشيل سيندروم، زي الكابر ليفل لما يعلى، الويلسون سيندروم، فاحنا اللي بنسهل لهم الطريق. ميرسي، شكرا.
Thank you, Dr. Rona. Thank you all for your lovely presentations. وشكرا للحضور جميعا.